Thank you so much, Madam Chair, and thank you to all the witnesses. Dr. Wright, I'd like to start with you. You have talked about push-pull incentives. Specifically, I would like to drill down a little bit as to the role of the federal government. One of the suggestions we've heard today was that CIHR form a specific stream related to AMR. Is this something that you would see on the push side in terms of advancing research as a good recommendation? And then secondly, on the pull side, could you be more specific as to what you would see that the federal government should actually do on as an incentive to encourage development of new antibiotics?
Yeah, thank you for that. That's something I actually know about. So an increase in the budget to the CIHR for the fundamental upfront discoveries is a classic push mechanism. We're going to push the science. We're going to make this kind of science attractive to the best, youngest scientists that are available for us. So that would make a huge impact. On the pull side, this is where we're trying to actually pull discoveries into patients. And that's usually at the level of the best people who know how to do this are large pharmaceutical companies who know how to make drugs, can do this at scale, have the facilities to do this. What we have to do is make it profitable for them to do it. We do this in vaccines all the time, right? We promise vaccine developers that we're going to buy X amount of doses. And so there's no mystery to the vaccine developer that they're going to get their return on investment. We don't do that with antibiotics, and we should. And other countries are doing this, Norway, the United Kingdom, and hopefully Canada too going forward. It's especially a challenge for us because we have such a small market. We need to get these drug companies excited about selling their products in Canada because it is so small. But if they had a guaranteed income, they would do it.
Thank you. Dr. Semret, very involved obviously in surveillance and stewardship and so on. One of the recommendations we've heard at this committee is that we should look more closely at long-term care facilities for both stewardship and surveillance. We do have, as has been pointed out by many of you, a very fragmented system in terms of data collection across the country, within countries, between institutions and so on. But would you see it as an important source of information if we look more closely at long-term care facilities?
Yes. Sorry. Yes, absolutely. I think we need to expand definitely beyond acute care hospitals. In my remarks, I think what we should recognize is the fact that the reason we're not doing it in the community or long-term care facility is because of the resource-intensive nature of performing effective stewardship interventions. But if we start coordinating to make some of these definitions more pragmatic, and if we have better ways of implementing stewardship, I believe it will be very organic and very natural for these good practices to be deployed across the spectrum of healthcare institutions. I think there's many things that we can do before forcing, sort of mandatory stewardship programs in settings that are poorly resourced.
Any time left, Madam Chair?
Yes, you've got 1 minute and 19 seconds,
Excellent.
Helena.
Dr. Bogoch, we've heard the tragic story from Ms. Neudorf related to sepsis. I think most of us have been aware of MRSA, VRE, Clostridium difficile, and so on as being very difficult infections to treat. So in your experience as a clinician, what kind of progress are we making? Are we lacking, again, some appropriate new antibacterials, antimicrobials? And what is your experience around some of these very tragic situations?
Thank you. Yeah, it's very challenging. I mean, anyone who practices hospital-based medicine, either it's an infectious disease physician, a general internist, a surgeon, an intensivist, you're going to see these every day. We see these every single day. Much of the time we have the existing tools, but when we don't have the existing tools, we have to go through the SAP program, which is extremely cumbersome, and it actually delays care. There are drugs that we just don't have available to us that we need. Sadly, we're needing them more frequently, and it's easy to say the SAP program doesn't work, is cumbersome, is outdated. But I think it's time to actually implement something better. And it would be a good idea to get smart people in the room to sort out a much more efficient mechanism to gain timely access to antibiotics that we don't have available to us readily, that we're needing more and more.